and welcome to More on Health. This video will be a small recap on a portion of what I typically do when I come into my long-term care facility. So I'm an adult health nurse practitioner. I am a registered nurse with an advanced degree. I have a master's degree. You can have nurse practitioners who may have a master's degree or a doctorate degree. Some nurse practitioners also may have a PhD as well. There are 4 types of APRNs, Advanced Practice Registered Nurses, and NPs. We are one of them. So I manage long-term care, skilled nursing facility patients. And when I mostly see my skilled nursing patients, referred to commonly as SNF patients. And when they are first admitted into my facility, I cannot advocate enough. You must, and I mean you must, thoroughly go through their hospital summary. If you were not provided with a hospital summary, order one. If you are not provided with the results from their diagnostics, their labs, their scans, from whatever hospital they came from, order from your medical director's office or medical records to get that information to you stat. Because you want to have a good idea of what is your patient's baseline from when they left the hospital, should they come to you from a hospital, and where they were prior to being admitted to that hospital or coming to you to be a SNF patient, meaning they were going to receive rehabilitation to increase their endurance and their strength to help transition them back into the community. And transitioning that SNF patient back into the community means either going back home or going back to their family member because they're no longer able to care for themselves independently, or going to a long-term care facility other than my long-term care facility due to whatever reasons, or going to an assisted living facility or independent living facility, or that basically covers where they can be transitioned to, right? Or if they unfortunately pass away, but we're not going to talk about patients being demised, because hopefully all my patients gain more health and they transition to a place where they can continue their optimal level of health and wellness. So back to how I manage my newly admitted patients. You must go through their chart. You must do a concise and stringent medication reconciliation process. Come back in a minute. Because typically what happens is when a patient is admitted into an ER for whatever reason, especially our geriatric seasoned population, right? They're coming in with an exacerbation of something or an acute something. And so the immediate response at the ER level is, let's get the patient stabilized. So sometimes the patient is not able to communicate whatever medications they were taking for their chronic condition, or their family members don't know what medications they were taking. And if it was a mad dash to the ER because of an emergency, they don't have time to grab the medication bag or all the pill bottles that loved one may have in their medicine cabinet or on their kitchen table or hidden from the family because your elderly family members don't want to let you know what they're taking or don't want to take. So you need to look at their past medical history, their current exacerbation or current newly diagnosed or primary diagnosis. Look at the list of medications that's on the formulary recommended by the hospital. See if those past medical histories, chronic conditions, if those meds line up. For instance, if you know you have a patient who's a diabetic and the only diabetic regimen on your formulary from the hospital is a sliding scale, 9 times out of 10, your patient might not have been on a sliding scale at home. They were placed on the sliding scale in the hospital because it was an acute, exacerbated situation where the body's under stress, and that was probably the best line of care for that diabetic patient who came in with that acute condition that has placed the body in distress. Now that the patient's more stable and ready for rehabilitation, this is your time to find out, were they really on insulin? Were they on long-acting insulin? Were they on pill form to manage diabetes? Were they ever on insulin? So it's imperative if you do a medication reconciliation And to address the epidemic with the usage of opiates across the United States, you need to pull a cures report, that is CURES. You need to be logged in, signed up, and utilizing the cures system to help eradicate the mismanagement, the misusage of unnecessary opiates for our patients and the community at large. And see whether or not your patient even been on narco or Percocet or oxycodone or any other controlled substance. Pull and utilize your cures report. I cannot stress the importance. And not to say that the patient doesn't necessarily need or require pain medication, but you want to have a baseline. What was the patient's history when they were using opiates, and if they were using opiates in the past? Maybe their newly knee replacement requires the use of pain medication. Do you need to provide Oxycontin for your opiate naive 80-year-old patient? Probably not. Maybe you can downgrade the level of potency of opiate for that 80-year-old patient. So you utilize your cures report, you utilize your stringent combing of your patient's hospital summary so that you can provide more in health and make sure that you are giving evidence-based, concise, clear care for our geriatric patients, any patients. But review your documents and utilize your resources. Stay tuned for more episodes for More in Health.